Welcome to the Industrial Athletic Trainers Society VNS On Demand. We are excited to share with you value-added continue education programs. Stick around at the end, or check the video description for more details on how members can claim their CU credits.
So welcome everybody. Really excited to have you here today. We are joined here by Dr. Kimberly Sisto. She is one of my esteemed colleagues here at Spalding University, and we were talking about one of her passions and one of the things that she kind of stumbled into as a career. I really thought this would be a valuable experience for the Industrial Athletic Training Society and those friends who've joined us here today. So Dr. Sisto, go ahead and introduce her. Dr. Kimberly Sisto is the Director of Clinical Education and Assistant Professor at Spalding University's Kaiser for Kids School of Physical Therapy. Dr. Sisto is a board-certified clinical specialist in sports physical therapy and holds her doctorate in physical therapy from the University of Michigan and Bachelor's of Science in Exercise Science from Eastern Michigan, so Michigan natives, appreciate that. With over a decade of experience in outpatient pediatric physical therapy, Dr. Sisto specializes in the treatment of pediatric pelvic health and orthopedic injuries. She collaborated to develop the sports physical therapy residency at Nationwide Children's Hospital and served as residency faculty and has presented at many local national professional conferences on the topics of pediatric pelvic health and rehabilitation of gymnasts. So Dr. Sisto, thank you so much for joining us today, and I will go ahead and turn it over to you.
All right. Well, thank you so much for the invitation to speak today. I am so excited to share a topic that is so near and dear to my heart. The title of my presentation is Maintaining Control, Understanding and Managing Urinary Incontinence in the Industrial Athlete. So just to tell you a little bit more about me and my venture into pelvic floor physical therapy. This is something that I never imagined myself doing, when I was in PT school or when I graduated. But as you heard a little bit earlier, I worked with a lot of gymnasts shortly after I got out of school. With gymnasts, there tends to be a lot of injuries. That was how I landed up being so interested in physical therapy. But working with gymnasts, I began to work with them, especially those with back pain. And I began to realize those times that I remembered my other teammates saying, oh, I got to go to the bathroom before I start tumbling because I'm probably going to leak, or, oh, I just felt myself leak. I got to go change. I realized how important that is and what a huge role physical therapists can play in the athlete. And then as I began treating athletes and then worked more into the general population of pediatrics that experiences urinary incontinence, I was able to make such huge drastic changes in my patients' lives. Kiddos that, couldn't go to sleepovers or were getting bullied at school were now coming to me and able to stay dry and so happy about what they were able to do and how they were able to participate. So it's really led to me being really passionate about this topic. So I hope you all will become more informed, and I hope to inspire at least some of you to dive into pelvic floor physical therapy and rehabilitation more. So this disclosure statement, just generally, this is for educational purposes only. It's based on current research, evidence-based practice, and my professional expertise. It does not constitute any legal, medical, or regulatory advice and shouldn't be used as a substitute for individualized professional consultation. I do not have any conflicts of interest or financial benefits or anything that may interfere with endorsement. And then, so I'm gonna move on to the next. All right, so learning objectives. I want to run through these real fast and things that I hope that you gain from my talk here today. So I'd like you to be able to describe the basic anatomical structures of the pelvic floor, including key muscles and their functions, and explain the relationship between the core and pelvic floor muscles. to be able to accurately define stress urinary incontinence and urge urinary incontinence and explain how these types of urinary incontinence specifically triggered or exacerbated by the physical demands of industrial work. I'd like you to be able to identify key risk factors for urinary incontinence within the industrial setting. I'd like you to be able to describe practical strategies for preventing and managing urinary incontinence in the workplace, and then be able to recognize the importance of fostering a supportive workplace environment that encourages open communication about urinary incontinence and reduces associated stigma. So today I'm going to talk quite a bit about urinary incontinence. So I want to start off with the definition of what it is. So urinary incontinence can be anything from just a few leaks to a complete void, what we like to call when you completely wet yourself or pee. What I'm going to really be focusing today are on stress incontinence and urge incontinence. And I'll briefly talk about the other two, but you can see this picture on the slide. It shows stress incontinence on the left. And what occurs when there's stress incontinence? There's leakage due to an increased abdominal pressure, and that causes increased pressure on the bladder, which lies right there underneath the abdominals, right? The abdominal region. And then there's also a weak pelvic floor that plays into that. Urge incontinence is due to the involuntary contraction of the bladder muscles when the bladder is full. Overflow incontinence is not something I'm really going to talk too much, but it is another thing that I would like you to be aware of is a reason for incontinence. And then neurogenic incontinence could be somebody with a neurological condition that is the root of their incontinence. So it's good to know that there can be other causes of incontinence and that it's important to make sure that if somebody is having incontinence and they're not improving with any interventions, we need to make sure that we're screening and referring as appropriately. So urinary incontinence is really prevalent. I think it's something that we don't talk enough about. In a survey of 17,850 adults, 20 years or older who participated in the National Health and Nutrition Examination Survey from 2001 to 2008, 51.1% of women reported urinary incontinence. So again, that's any urine linkage with physical activity before going to the bathroom or during non-physical activity. And then for men, the numbers were 13.9. So you can see there's a lower prevalence with men. Now the prevalence for stress urinary incontinence is a bit less. So for women, it's 37.5%. And then in men, it's less than 10%. So there are several risk factors that increase the risk for that somebody will have a stress incontinence or develop stress incontinence. So for both genders, we look at things like age. So as we age, a lot of times our muscles can get weaker and our body isn't functioning to its full capacity, right? We have maybe other health conditions and stuff that may affect this. Chronic cough. So if you think about coughing, that really involves a lot of stress and that inner abdominal pressure that we talked about. So extra stress on the pelvic or on the bladder. Heavy lifting. So think of those industrial athletes doing lots of heavy lifting. They're already, just with what they do, the nature of their work, they are at increased risk for stress urinary incontinence. Constipation. I will talk to you guys about that in quite a bit of depth coming up. Diabetes, neurological disease and injury, and then obesity. So for females, pregnancy and childbirth, as well as number of children, really plays into their increased risk of stress urinary incontinence. Genetic and connective tissue disorders is something that I see quite often in my practice. I see a lot of kids with generalized joint hypermobility or things like Ehlers-Danlos syndrome. And then I also see kids that are kind of just more floppy or low tone. And these kids grow up into adults. So if you work with primarily adults, you can see these things too. Obviously, menopause or hormonal changes can really affect our stress urinary incontinence, as well as any pelvic surgery. For men, prostate surgery and pelvic radiation are things that may increase their risk of urinary incontinence. So I talked a little bit about at the beginning about back pain and stress urinary incontinence. So there is a huge link between back pain and stress urinary incontinence. We'll talk a little bit more about the anatomy and physiology and exactly why there's that link. But I want to tell you a little bit more about the increased risk, the increased odds that somebody with back pain will have stress urinary incontinence. So in a Canadian survey, it was done from 2011 to 2012. It had over 125,000 adults that were surveyed. And there was an odds ratio. So the relationship between back pain and stress urinary incontinence was about 3 times as high if you have back pain that you have stress urinary incontinence. And for men, the odds ratio, pretty high for having back pain and stress urinary incontinence. The odds ratio is 2.45. Now, a systematic review, which had combined observational studies, had a positive for urinary incontinence and back pain or pelvic pain in association with 83% of the studies. And then there was an odds ratio of the stress urinary incontinence with the back pain of 1.61. So what does that mean? If somebody comes to you with back pain, it's very important to screen for urinary incontinence because that may be part of their picture, and the picture of getting them back to 100% may include addressing any pelvic floor issues. So let's dive a little bit deeper into anatomy. Okay, so I'm going to refer to the lower urinary tract quite a bit as we talk through things, but I want to kind of separate out the parts of the urinary system so you know better exactly what I'm referring to. So the upper urinary tract is composed of the kidneys, the ureters, and that's it. Okay, the lower urinary tract, which is what we're going to be talking about today, is the bladder, the ureter opening, so that's where the ureters go from the kidneys, give us that urine. It drains into the bladder. And then the urethra is the opening of the bladder, or I'm sorry, the urethra is where you void out of. Okay, so the process of micturition. So micturition just means the process of emptying your bladder. Okay, so the importance of it, right, is to eliminate metabolic products and toxic waste from our body. So what happens when we are needing to go to the bathroom? First, our bladder fills. Okay, so here's a picture of your bladder. Your bladder is a muscle. It's called your detrusor muscle. And when that bladder muscle, or when your bladder fills, that detrusor muscle contracts. So the stretch receptors of the detrusor muscle are then triggered. They send a signal of bladder fullness to your sacral nerves in the spine, which goes all the way up to your brain. And that's when you interpret it as, oh, I think I need to go to the bathroom. That's when you're able to say, oh, I really need to go right now, or I think I can hold it like 5 or 10 minutes. I'll be okay. So say your bladder's really full. You really need to go to the bathroom. Okay, you decide you need to go to the bathroom. So you go to the potty. What happens there? So parasympathetic motor neurons cause the detrusor muscle, right here again, to contract. The increased intrabladder pressure causes the internal sphincter to open, okay, and it relaxes. Then the urine enters the bladder neck and goes into the urethra. And then the external sphincter relaxes. And that is when urine is expelled from the body. So when we're thinking about pelvic floor and addressing the pelvic floor, we're really thinking of the action of the external sphincter because that's more in our control. So this is kind of how in the whole process that we're going through when we have to go to the bathroom. So constipation. So this is something that I see so much in the patient population that I treat. And I think a lot of people don't realize its connection to bladder function. So if you look at the picture here on the left, there is a impacted or very constipated person, an image of a person with a large fecal mass in the rectum. Okay, and what you'll see, this is a woman, right? So they're, so right here is the bladder. So we'll just not talk about everything with the ovaries and everything like that, the cervix. But here's the bladder. And so you'll see that it pushes on the, the ability to outflow through the urethra, right? So the other thing that can happen too is it changes the shape of the bladder. The bladder capacity might not be as great. Okay, so you can see the differences in those, and we already have a risky situation here. If somebody is constipated and their bladder can't expand and contract as it should, right? And so we're already in a risky situation right now if somebody's constipated. Also, if they're super constipated, what happens to the pelvic floor is it stretches out and it drops even more. So its ability to contract has decreased. And so that's something that is something I'm always looking out for when I am assessing my patients. I'm looking for any signs of constipation. So here's a good picture of a bladder being squished. But the general population has such a high prevalence of constipation. So it's something that isn't talked about very much, but it's a very important part of our body function and can tell us a lot about a person's general health and something that should really be addressed. So we'll talk a little bit more about easy ways, tips and tricks, things that you can do to assist your patients, which are things actually you're probably already doing. Okay, so let's dive deep into the pelvic floor now. So there are three main layers of the pelvic floor. I'm going to go over the two that are most important. So right here, you can see a picture of the urogenital and anal triangle. So you'll see the urogenital triangle right here, more at the top. This is a male. And then the anal triangle is on the bottom here. Here is the anal triangle in the female, the urogenital in the female. So the urogenital and anal triangles, these are the most superficial muscles of the pelvic floor. You can see they make triangles, and that's why we call them urogenital and anal triangles. So their function is sphincteric. So what they do is they help close off the openings of the anus, right, and the urethra. Okay, so their job is to stop the passage of gas or the flow of urine. So they're very fast twitch muscles. Things like bowel and bladder urgency is really affected when these muscles aren't working the way they should. Now deeper is the pelvic diaphragm and the levator ani muscles. So these are supportive muscles, and they support our internal pelvic organs and also resist intra-abdominal pressors. They are slow twitch endurance muscles. So they're the muscles that are activated when we're dealing with things like stress incontinence. So if we're really targeting a person with stress incontinence, we're going to need to work on endurance training of the pelvic floor and the associated muscle groups, which we'll talk about very shortly. So associated muscle groups. So the pelvic floor works in combination with the core, like a pressure system. So at the very top, we have the diaphragm. So that is our key muscle of inspiration. It helps us breathe in expiration. It's our breathing muscle, right? So there is an interaction between the diaphragm, those abdominal muscles, your pelvic floor, and then the erector spinae muscles in the multifidus. And this pressure system works together to allow for movement of not only the diaphragm, but the intra-abdominal contents, right, in the pelvic floor. So when we inhale, I want you all to place a hand on your chest for me. I'm going to do a little activity here, and press a hand on your belly for me. When you breathe in, I want you to tell me what you feel. So as you breathe in, what do you feel your belly do? Nice, deep diaphragmatic breath. So yes, so we have expand come up here. So yep, so our abdominal wall expands and the pressure increases in our intra-abdominal area when we're breathing. Our pelvic floor at the same time, that's right there. That's connected to the abdominals. If you look right here, if you looked at the rectus abdominis, look, there's a connection there. The rectus abdominis, our obliques, our transversus abdominis, they're all right there. And there's that great connection right to the pelvic floor. Okay, so the pelvic floor drops and lowers as we inhale. And then your back muscles, your erector spinae, your multifidus, it provides that support and structure for that pressure system to continue and work. And then as we breathe out, right, the diaphragm goes up, pushes the air out of our lungs, our belly comes back in, so we have a decrease in that intra-abdominal pressure. Our pelvic floor rises. There's not as much pressure pushing on that pelvic floor. And then that back stays that supportive back that it was with those muscles. Now, I tell all of my patients, if any one muscle is not working the way it should in this pressure system, it throws everything off. Okay. And so that's my job as a pelvic floor physical therapist, but also as your role working with industrial athletes is to look at that whole system and make sure all of those muscle groups are working and interacting together the way they should. So we're preventing any issues, including stress urinary incontinence. So next, I have a picture of exactly what's going on with the bladder with stress urinary incontinence. We talked about this a little bit earlier, but I wanted to review it once again. So a normal bladder, when we have stress urinary incontinence, it will be filled, right? It's got some urine in it, but our sphincter muscles are contracted, so our internal and external sphincters. And our pelvic floor muscles also provide some extra support. They help to make sure that that external sphincter is closed. But when you have a weak pelvic floor and you got a lot of pressure from the abdominals, what happens is that you get the relaxation of your sphincters and then you get leakage. So I thought I would give you all this because this is something that is very helpful. It's kind of a pelvic dysfunction screening protocol, and it's something that you can do to give to somebody. It's nice because it's just a piece of paper that you can hand to somebody and have them check it out. You don't have to always ask those sometimes more uncomfortable questions. But this is something that you can do to screen a patient or an industrial athlete that you're working with, and really see if they're having significant issues with pelvic dysfunction. And if they say are not improving from you, or you feeling it's something that you can't, manage, and you would like to send them to a pelvic floor PT, you can find that, they probably would benefit from some therapy if they check 3 or more boxes. Okay, so everybody gets a little bit nervous when I talk about pelvic floor physical therapy because you think, oh goodness, we're going to have to do an internal assessment, right? And have to have the patient take their clothes off and do a full assessment to figure out what's going on. But actually, there's so much that we can do without directly assessing the pelvic floor. So I understand that probably a lot of you will not directly assess the pelvic floor, which is absolutely fine. But I want to give you tips and tools and things that will help you when you're an outsider to kind of integrate things about the pelvic floor and pelvic floor therapy to any industrial athlete that you're working with. And that can just really make a big difference, and actually in some cases probably will resolve their symptoms. So, as a pelvic floor physical therapist, I do more, in-depth assessment, but with pediatrics, the lovely thing is I don't do any internal exam. I do exam more externally. So I'll even have patients in their yoga pants, and I'll just feel for their muscle contractions. But things that I'm looking for, and that you could even observe without even touching them, is just, can a patient contract and elongate their pelvic floor? So squeeze, I want you to hold in your pee. Or push, I want you to push out like you're pooping. Those are little cues that I like to give them. You can look at the endurance of the pelvic floor. How long is a patient able to hold a pelvic floor contraction? Are they breathing when they're pushing out like they're pooping, or are they straining a lot? Also, things like excessive abdominal gripping and activation, or use of their hip adductors if they're trying to squeeze like they're holding in their pee, even use of their glutes. That patients are frequently doing this to assist or compensate for the pelvic floor contraction. So these are things to look at. So you don't even have to, do any assessment of the pelvic floor directly. You can see by palpating if their adductors are squeezing, and you can also see the movement of their legs, right? If their hip adductors are squeezing, or if their glutes, if you have them in like a child's pose position, it's really easy to see. If you have them do a pelvic floor contraction, are they activating their glutes? You can usually see that if the patient is wearing something fairly tight or something more form-fitting. So these are ways that you can externally assess the pelvic floor without actually really doing any internal work. All right, so other things that you can assess that really affect the pelvic floor's function. I'm going to start with flexibility. So flexibility and range of motion. So we just talked about the hip adductors, right? And those muscles connect right by the pelvic floor. And a lot of times you'll see people, you probably have heard about the potty dance, or, we adults like to cross our legs a lot. We may do it when we're standing or sitting, but it's a withholding behavior in a way to kind of prevent that urge to go to the bathroom. So people that have an overly active pelvic floor will typically cross their legs. Those are the patients that I see that I would consider hypertonic. They're just really tensed up and don't want to relax. But in your assessment, that may show through that they have really tight hip adductors. And that may be something you want to target when you do interventions. So next, the hip rotators are something that can really affect their motion, right, in the pelvic floor. So our pelvic floor muscles are highly ingrained with our rotators and then our glutes. They're just right next to each other. So looking at the motion there can highly affect pelvic floor function. I always like to tell people that I'm talking to about pelvic floor therapy. I had this patient once. She came in to me because she had femoral anteversion. So that's when the head of the femur is turned inwards. So what happened was she actually had a shortening of her pelvic floor, and she was having so much pain. She was constipated. She couldn't poop. The femoral anteversion, the orthopedic surgeon was like, well, we don't have to operate. I don't think it's, quite bad enough. But here she was having to go to several different doctors for issues with constipation and urinary incontinence, just related to her pelvic floor function. That was secondary to her pain because of her muscle restriction and tightness from that femoral anteversion. So a reason that it's really important to screen for those hip rotators is because it can really affect that pelvic floor function. not only the bladder, but also the bowel. And then the trunk. So we talked a little bit about the importance of the abdominals and the spinal musculature, and its importance in support of the spine in the back. And so that is something that we also want to look into and make sure that patients are in the proper position when they're doing things like going to the bathroom. So when we talk about postural alignment, that's another thing that's really important. This picture here at the left shows you that relationship. Again, we talked about it earlier between the diaphragm, the abdominals, and the pelvic floor. Now, somebody that's got that real sway back posture, excessive lumbar lordosis, it's going to be an issue with their pressure system, right? Because our pelvic floor is not aligned with our diaphragm. So when they aren't aligned, we can't produce the proper pressure for a bowel movement, right? It also makes it harder to go to the bathroom. And if you're lifting, it's really going to cause a lot of increased risk for stress urinary incontinence. So assessment, other things to look at. So I know that you all are used to assessing core strength. So looking at the lower abdominals with a double leg blower, your just traditional plank. So you're looking at more endurance, right? Your core stability. So looking at that bird dog position, and the use of the multifidi is very important. And then functional strength. So looking at movement patterns, general movement patterns of a patient. So, are they using faulty movement patterns when they're lifting boxes? I'm sure this is something that you are well versed in, but hopefully I'm giving you a different lens to look at this through and another dimension to think about when you're assessing or working with patients or your industrial athletes. Okay, so the management of urinary incontinence. So the first thing I always start with patients that come in to see me for pelvic floor physical therapy is just basic good bowel and bladder habits, because they so affect pelvic floor function, and they're so integrated in the pelvic floor, in pelvic floor therapy. So we're going to go over all of these in the next few slides, but the first one is education and demystification. Then we're going to go over behavioral modifications, lifestyle advice, symptom registration, and then support and encouragement. We'll go through that. Okay. So education and demystification. So it's important to let your patients know that a lot of people have urinary incontinence, right? We already talked about 50% of women and 13% of men. And then stress urinary incontinence, we get into numbers of 37.5% and below 10% for male. But that's still really high, right? We need to normalize this and make it okay to talk about issues with leakage, right? This is something that's normal, right? It happens, but it can be resolved. A lot of people think that, oh, well, I'm just going to have to wear a pad for the rest of my life. That's what happened to my mom. It's going to happen to me. That's the same thing. But no, it can be resolved. It's not a lifetime sentence when you have these issues. And then also, it's really important to explain normal bowel and bladder function. So we're going to talk about that a little bit in our next slide. So what is normal bowel and bladder function? So going to the bathroom, going pee every 2 or 3 hours is normal. Sometimes I meet people, especially those healthcare workers, that are like, well, I just don't have a break. There's no way I am not going to be able to go to the bathroom, from, the time I start seeing patients at 7 a.m. until noon, my lunch break. That's 5 hours. Okay. Definitely not something that is good for our bladder, but something I understand can be an issue sometimes, but doing your best to avoid every 2 to 3 hours is so important. Waking up once or not at all during the night to go pee is normal. Okay, any more than that is considered abnormal. A lot of people just brush it off and say, oh yeah, I'm always getting up to go to the bathroom throughout the night. That is not normal. I think you need some help. Also, you should feel bladder fullness when your bladder is partially full. So you should not feel bladder fullness only before, right when you need to go to the bathroom, right when you feel, a dribble of urine coming out of you. And then bowel movements can range from 3 times a week to 3 times a day. Okay. And so if you look at the Bristol stool chart, I ask my patients constantly, where are you on my poop chart? Being between type 3 and type 4, which is like a little bit lumpy, but mostly like a long, softer log, that's where you want to be. Otherwise, it can indicate other things. Severe constipation, if they're more of that hard, lumpy type of stool. And then the more softer bowel movements and feces are considered somebody that's lacking fiber or even diarrhea. So behavioral model modifications. So first of all, regular voiding. So we talked about going to the bathroom every 2 to 3 hours. Then proper voiding posture. So the way we best can defecate and poop is if we squat. We're in a squatted position. So in Japan, you know how everybody squats to go to the potty, that they're really doing things right. It is because our puborectalis muscle is relaxed when we're in more of a squatted position. And it allows the rectum to be straight and for you to get everything out when you poop. So I always tell my patients, I want a stool underneath you and your knees should be at least the same height, if not higher than your hips when you're on the potty. The other thing is you want your legs to be apart. If your legs are together, you're not going to allow that pelvic floor to relax and allow you to get everything out. Also, when you think about any holding or with proper voiding, you want to think about that relationship with the diaphragm and the pelvic floor and just thinking about making sure that you're breathing instead of holding your breath. So any holding maneuvers, so we want to avoid those. We talked about those a little bit earlier. And then constipation management. So we're going to talk about that on the next slide. So fluid intake is hugely important. So recommendations, which I'm sure you guys are aware of, are 11.5 cups for women and 13.5 cups for men. But that includes anything from food. So really, I think when you take food out, they generally say food is about 20%. So more like 9.5 for women and then 11.5 for men. And then we want to make sure that our patients are avoiding bladder irritants and, or at least very aware of what bladder irritants do. So what bladder irritants do can increase urinary urgency and frequency. So those times you have to run to the bathroom to get there in time, or you have to go to the bathroom all of a sudden very frequently, every 15 minutes, every 30 minutes. So things like caffeine, citrus, any carbonated beverages, artificial coloring, or chocolate are things that can cause that irritation of the bladder and cause you to go pee more frequently or have some urgency. For diet, we want to make sure that our patients and our industrial athletes are getting plenty of fiber in their diet. So 30 grams of fiber is a recommendation per day. And we want to avoid really constipating foods. If somebody really has a history of constipation, things like having excessive dairy, bananas, peanut butter, and processed foods are all things that can trigger more constipation and should be had just in moderation. And then, as you all know, physical activity is so important, right? So it helps regulate and improve the regularity of your bowel movements. Okay, so symptom registration can be really important. This is just a bladder log and a tracker just so you can see, and it also lets your patient know, or the industrial athlete that you're working with know, that exactly what Their triggers may be that caffeine, maybe I'm having to go pee right away, or, those times of the day when you're more likely to leak. Just is a tracking log, and this one's way more in depth. Sometimes mine just includes kind of like what you're eating, what you're drinking, when you're going pee, if you have any leakage. So it can be as in-depth or not, as you would like. And then support and encouragement. So something that you guys are already used to doing, right? But understanding, being that person that is supportive, of the person, their health condition, but also normalizing what's going on for them. Telling them, yeah, like this really happens really hard, but it's something that we can do. There's something that we can do to help make it better. Okay. So what do we do to make it better? So it's more than just Kegels. So many people are like, well, pelvic floor physical therapy, that's just Kegels, right? Well, no, you already know from the assessment that there's so much more to addressing somebody's pelvic floor than just Kegels or pelvic floor contractions, right? So things on the next slides that I'm going to address are listed there. So stretching. Stretching is so important. We want to think about stretching out the pelvic floor, stretching out those hip adductors, right? Doing that butterfly stretch, the happy baby stretches are two of my absolute favorites. Those hip rotators are also very important. Diaphragmatic breathing, right? Because we just talked about the connection between your diaphragm and your pelvic floor. We need to make sure the system is working properly, right? But also thinking about the coordination, right? Because there's coordination when we go to the bathroom, but also the coordination of the breathing with the pelvic floor. So making sure that there's good use of the diaphragm and not those accessory muscles. Biofeedback. So biofeedback doesn't just have to be placing stickers on a muscle or muscle group and seeing, on a computer if the muscle's activating and when it's relaxing. Okay. We can do biofeedback by helping a patient to identify when they are having a pelvic floor contraction and when they're elongating it and when the pelvic floor is just at rest. So those are things that can help to improve awareness. And overall, I think that's one of the most important things to help a patient that has issues with urinary incontinence, any dysfunction of the pelvic floor. It really helps them to understand and be able to know, oh, I need to relax. I'm turning my pelvic floor on right now. Or, oh, I'm really pushing way too much when I'm lifting or when I'm holding something. So other exercises that we can do. Remember, we need to focus on our breathing and use of the pelvic floor in contraction as appropriate with your pelvic floor, with your core stabilization exercises. So thinking about your lumbar stabilization exercises, your glutes, working on that whole area, all of those muscles that interact with the pelvic floor and those hip rotators. They're so important that you address all of those things, but you integrate the breathing as well as a slight contraction of the pelvic floor while you're doing these exercises. And then let's start on functional training. After we've mastered the pelvic floor contraction and the use of the pelvic floor with more basic exercises, it's time to try it while we're doing things like squatting and lifting boxes. Can you contract that pelvic floor a little bit? Probably a 7 out of 10 while you're doing that squat. I want you to do it at the bottom and as you're lifting to come to the top. Okay, when you're doing a lunge, I want to see if you can keep your pelvic floor engaged. 7 out of 10. 10 is the max squeeze of your pelvic floor. I want to see if you can keep it engaged the whole time you're doing lunges. So remember, we want to work on endurance with these muscles. So I'm not looking for a full contraction. It's a little bit less than that. And we want to sustain that contraction. So thank you so much for listening to my session here about pelvic floor and its role in stress urinary incontinence and the industrial athlete. And I'll take some questions if you all have any questions.
one question here. What if you have a pregnant patient and they are going to the bathroom more than once during the night? Would that be considered abnormal?
No. So for the pregnant patient, that's very normal to get up and have to go to the bathroom more frequently. I think that, a lot of times our bladder gets into the habit of postpartum, still getting up like that and going frequently. And that is not normal. So that's something postpartum to really address. But that shouldn't mean that, the person is getting up 5-6 times a night to go to the bathroom. That's abnormal. I'd say 3 times would be kind of the maximum of what I consider normal for a pregnant woman in the middle of the night.
I've got a couple questions here.
Yeah.
So in this case, I know you might not have all the information you need to make best decision here, but so I wrote down here what would you think or advise for folks or patients that have difficulty going to the bathroom, and then in the same day they can't control it? So you're kind of going back and forth between unable to and then having difficulty controlling it.
Yeah. So I do see this quite a bit in my practice. So first, I would make sure that they are screened and maybe seen by somebody to make sure there's a rule out of any neurologic condition that can affect this. One of the big things I like to screen for with my patients is that if somebody has hesitancy and it takes more than 6 seconds, that can be a potential indicator of a neurologic condition. So that's something that should be referred to a urologist. If they're having these issues with hesitancy and then frequency, the best place to start really is to get on a normal voiding schedule. So try to make sure that they're voiding every couple of hours and doing that throughout the day. I'll find that some people will go to work and they'll go for 5 hours and won't go pee. But then when they get home, it's like a completely different thing. And they're voiding all the time. So normalizing and getting that normalized is so important. But also, I like to tell all my patients that our pelvic floor muscles, we can hold stress in them. Okay, it's a flight or fight muscle. So starting to think about that autonomic nervous system, right? If we have any stress or tension, we may be contracting our pelvic floor, because if we're running from a bear, is the first thing we want to do go pee? No, we got to hold it, right? So that autonomic nervous system is set off and it stays contracted. And so what happens then is if that pelvic floor is contracted, you're not going to get those signals of I need to go potty like I should, or you may become constipated because you're not getting the signals that you need to poop. The other thing to think about in this situation is there a component of constipation? Because a lot of times a full bowel really impacts the urinary function. So I'll see a lot of people that complain of these issues that are constipated as well.
Andrea has a question here, but to follow up with one of your statements you just made, can you talk about the importance of workplace accommodations for folks? Like a doctor says, like they have to, instead of just writing, I'll rephrase this. A lot of times I see like doctors will just write needs to have access to frequent breaks. Can you talk a little bit more about like the importance of why it's important to have that type of accommodation in the workplace?
Yeah, so it is so important to normalize function. I tell my patients, if you are not doing these things all the time, you will not get better, because we are retraining your body. We're retraining the system. And if you're only doing it half of the time, we're not going to see the changes. So it's important to make sure that you're an advocate and give that information to your industrial athlete about that normalized voiding. Yes, at every 2 hours, you need to be able to get up and go to the bathroom. And the doctor needs to state every 2 hours. Be very specific. And those accommodations do need to be made for a healthy person. You shouldn't have any health conditions because of your job. Your job shouldn't create any issues. And also thinking about, you're probably better able to do your job if you don't have to hold and pee, right? So, yeah.
So I think that was a perfect segue to Andrea's question here. It says, how many times a night is, I'm sorry, is that the right one?
So,
How many times a night is normal for your average adult to go to the bathroom? Maybe, and also what's normal for folks to go to the bathroom?
yeah. So none at all or once a night is considered normal.
Okay, per night. And then like throughout the day, if you assume that someone's eating and drinking the correct amount, what do you think would be considered normal there?
Yeah. So, I mean, are you talking about during the night?
Throughout the day.
Throughout the day, I'm sorry. So throughout the day, it can vary anywhere from 3 to 8 times is considered normal.
I feel like I've been taking all the questions. Anyone else?
I just typed one in.
Chris here. Do you have any easy external ways to determine if UI is due to overactive versus underactive pelvic floor musculature?
Yes. So there are some hints with tight adductors, right? But for me, if you do external palpation of the pelvic floor, so a lot of times what I'll have a patient do is go into a sideline position, and I'll palpate about an inch from where that anus is. And what you have them do is, I tell them to squeeze like they're holding in pee and holding in a fart. And a lot of times you'll feel a lack of a rise in that pelvic floor. You won't feel as much motion as you would be considered normal. And also when they push, you'll feel like they aren't able to go as far either. So those are kind of things that when you externally palpate, you can feel. But you can't necessarily tell just muscle tension wise by just looking at it necessarily. It's a bit harder. So it's more with the movement that you're able to kind of decipher that. And then also you get some cues from some of the subjective history that your patients are giving you. If they're saying they're crossing their legs a lot, if they're really stressed, if they are just a person that sometimes just, we have a tendency, some people are just more type A, go, anxious, maybe somebody that has increased risk factors for having more of a hypertonic pelvic floor. That was a great question.
Looks like I've got another one here. I notice feelings of incomplete emptying on pelvic floor screening tool. Do the same recommendations for diagnosis and care stand in these cases? So notice feeling of incomplete emptying on the pelvic floor screening tool.
Yeah, so the feeling of incomplete emptying is very important. That's also something that needs to be looked at by a urologist too. Pelvic floor can hugely affect that, but there are other things. Your kidneys can be affected if there is incomplete emptying, which is why pelvic floor can be so important. But it's important to screen it and figure out why there's incomplete emptying. So it may be something that's a pelvic floor function, but it may have a larger stem, or it may have impacted, say, the kidneys, the ureter more. So very important to address with any pelvic floor interventions.
This concludes the IATS On Demand Continuing Education Program video. To claim your CU, you must be a member of the Industrial Athletic Trainers Society and complete the form Claim Your CU found in the YouTube description. If you have any interest in learning more about what the Education Committee has to offer, reach out to the email address on your screen. If you would like to volunteer your time to speak on a topic that interests you, please reach out. Thank you and stay safe.